Okay, so very last, Sasha Gusev, who has a PhD in computational biology and now is an associate professor at Harvard Medical School and also here at the Farber. And you've been interested in cancer genetics, and I've been particularly interested in your work on genomic predispositions for cancer and also immunotherapy response and toxicity predictions. So very much looking forward to your talk.
Thank you guys for sticking around. So it's, I guess, the privilege of being the last speaker is that a lot of the introductory material I have has already been covered in a lot of depth. So you guys should all be pretty familiarized. I'll try to rush through it. And in general, my goal here is to present one specific and I think relatively straightforward application that we have been working a lot on for immunotherapy, toxicity, and outcome prediction, and then kind of think about how both this can be a tool and maybe extended to other biomarkers. So I will go through a little bit of what other speakers discussed in terms of the high points of why we care about immunotherapy toxicity in this setting. And so obviously, immune checkpoint inhibitors are a double-edged sword. There are exceptional responses for a subset of individuals. Oftentimes, the more combinations or the more aggressive the treatment, the better the response. But then these come with these substantial side effects. And it's still, even like in Dave's table from the beginning, it still shocks me that you have clinical trials with grade 3, which are really meaningful severe adverse events happening sometimes in 50% of cases. So this is not like what I think of as a side effect that's in 1 in a million or something. This is like a side effect that is really presenting frequently. And then the other side of it is, I think we know a lot less about this, but that some of these toxicities can then develop into chronic and severe lifelong conditions for these individuals. And, for advanced disease where your choice is often disease progression versus taking this risk, probably take the risk. But as these treatments are being moved into earlier and earlier stage settings where either the patient doesn't have the cancer and you're thinking about an adjuvant treatment, or there are other options for them, then this question of whether to essentially run the risk of giving them a lifelong autoimmune condition as a consequence of the treatment becomes a more substantive question. And so I think in some sense, when we started working on trying to predict these events, the critique that always came up was there's never an instance where we wouldn't give immunotherapy to a patient over toxicity. I think that is changing over time, especially in this earlier stage setting. And there's this complexity which has been observed in, it's sometimes subtle and it depends on how you model it, that toxicities can be associated with positive response as well and be a positive biomarker. Eugene talked about this a bit in his presentation. On the one hand, a mild condition may be an indication that the treatment is working and everything is great and the patient should just continue along. Or it could be an early warning that they will eventually develop a severe toxicity that requires taking them off the therapy. And so this creates like a really complicated clinical decision where you don't know if something you're seeing in a patient is good news or bad news, and necessitates, again, trying to stratify individuals as much as possible. The specific focus that I'm going to be talking about is the germline component, which I don't think has been mentioned too much. And the kind of rationale for this is that oftentimes these toxicities in the immunotherapy setting look a lot like conventional autoimmune conditions. And we know that autoimmune conditions in the general population have a very strong inherited component, particularly in the HLA region, but also a polygenic component. And so there's reason to think that a genetic predisposition to an autoimmune condition or other immune dysfunction then gets sort of activated by the treatment in these patients. And we should be thinking about what inherited mutations they're coming into the clinic with as well. The way that we have been doing these analyses is actually somewhat paradoxically working off of somatic sequencing data. And I won't get into the details, but the most sort of routine clinically collected genomic data is tumor panel sequencing. There's an enormous amount of tumor panel sequencing that happens here at Dana-Farber. And because I'm a germline geneticist, we worked really hard to show that you can, in fact, go back to the raw data, infer genome-wide common germline polymorphisms from these sequenced panels. And so we've turned a somatic sequencing cohort into a germline somatic sequencing cohort where we can now run these genetic analyses. And the study I'll be talking about, at least the discovery effort here, focused on about 3,000 patients treated with immune checkpoint inhibitors at Dana-Farber. And again, that's sort of small potatoes by genetic analysis size. Like there's a lot of biobanks now that are in the millions. But in terms of patients on a treatment, this is actually one of the largest cohorts that anybody I think has been able to put together. And then additionally, an important logistical component of this is collaboration with other folks, with pharma, with other institutions, and we worked with Eugene's lab on this as well to be able to replicate the associations in independent cohorts, some of which were directly genotyped, some of which were imputed using the strategy I described. And then finally, because we have access to the sequencing data from all patients at Dana-Farber who consented, we're also able to look in a sort of normative population who was treated with other systemic therapies as a comparison group. So what does a genetic analysis, a germline genetic analysis actually look like? We're running a genome-wide association study. This is sort of the workhorse of how people have been identifying variants associated with conditions for the past 15 years or so. And the basic idea is that we walk along the genome and we ask for every single polymorphism, is there a higher frequency of that variant in cases versus controls? And because we know that the genetic variant preceded the condition, it's fixed at conception, this is almost always, outside of some artifacts, a causal relationship between the inherited variant and the outcome. In our setting, it's a little bit more complicated than that because we're not really talking about cases and controls. We're talking about the time until you develop a toxicity, as well as the competing risk of death, which we model here to avoid issues with survival bias. But ultimately, this is a sort of multi-state survival analysis that's done genome-wide. When we run this analysis in that discovery cohort, we identified 3 associations at the sort of established standard of genome-wide significance. So correcting for the number of tests, the millions of tests that we ran across the genome at these 3 loci. And we've been focusing on this IL-7 gene association where we think there's the clearest biological signal, but in fact, these 2 other loci kind of merit additional follow-up as well. So how do we make sense of that Manhattan plot that I showed you? I'll kind of walk through step by step how we deconstructed this mechanism and what way it may be useful ultimately for patient stratification. So first of all, we want to know that this, to what extent this association is cancer type specific or heterogeneous. And what we see is, in fact, it's pretty homogeneous. There are nominally significant associations in 6 different cancer types within our analysis. Some of the strongest effects are in kidney bladder and also in melanoma, which is one of the largest populations here. But we generally see either a pretty consistent effect or error bars that are too wide to interpret anything within one cancer. We additionally replicated this association, as I mentioned, into external cohorts. One which was very deeply phenotyped for toxicities at MGH in collaboration with Eugene and Carrie Reynolds, and then an additional replication cohort, which really did just land at P of 0.05, and I actually still don't know if that's considered significant or not, but at Roche. And we've replicated it in other studies since then. So for this association, we are quite confident that this holds up. In particular, and now kind of switching to the context of melanoma, we collaborated with the lab of Ben Fairfax in the UK, who had a genotyped cohort with IRAEs annotated as well. And what's really nice about these sort of germline associations is we can just send him the RSID and he look it up in his data set and see if it's associated or not. There's very kind of minimal specificity because this is just an inherited polymorphism. In their cohort, they were able to replicate the association. They see the strongest effect in the single agent immune checkpoint blockade. Again, you see the varying use of terminology here, where actually in single agent, this variant has an odds ratio of 6, meaning that about 50% of the carriers of the polymorphism developed an adverse event, whereas for the non-carriers, that rate was something closer to 6 or 7%. And this is massive by inherited variant standards. I'm not aware of a common polymorphism for any condition that has an odds ratio of this magnitude. We don't really know why the effect is so large, but you could sort of hypothesize that generally speaking, large effect variants in human history get selected out of the population because they're deleterious and they slowly reduce fitness. This is a variant that appears to be treatment specific to a treatment that obviously didn't exist for the majority of human evolution. And so, it's a little bit of a just so story, but it's possible that these treatment specific effects are going to have larger effect sizes on average because evolution hasn't had a chance to bring them down to lower frequency. In any case, the effect size is what it is. And for carriers, there's already, just from this one polymorphism, fairly substantial positive predictive value.
So actually, what's the allele frequency?
So it's about 7% for the polymorphism. Yeah. It is. So it's a good question because allele frequency could be one way to kind of tease out this evolutionary hypothesis a little bit more. We do see that it's more common in East Asian individuals. It's like 25%. And then I think even slightly more common in African ancestry individuals, closer to 30%. So there does seem to be more variation across populations than you would expect just by chance. We haven't really done like formal kind of evolutionary testing of selection at the variant itself, but it's generally common globally.
So if you look like, typically East Asians are significantly more likely to get toxicities from checkpoint blockade in general. So I wonder how much is because of this carrier status versus other vectors.
Yeah, we've been thinking that as well. We have, I forgot to put it on this slide, but we have a replication with the Korean group that collected patient data from a largely Korean cohort. The effect is there, but it's weaker. And so we don't know if, even though it's more common, it's somehow being dampened in its magnitude. And so it will not explain, the overwhelming disparity in toxicities. That's the only non-European cohort we've been able to look at. And we also don't know how good their toxicity annotation is, which is like always the elephant in the room here is that any heterogeneity of effect could be a matter of they just phenotype or report these events differently. So I think it's sort of a glass half empty, glass half full situation. The effect is there, but the only estimate we have of it is significant but less substantial.
Sorry, is there a phenotype of them?
There is a very small number. There are a small number of homozygous cases. It'll be less than 1% of the population.
Yeah.
We don't have the power to test for like deviation from additivity. And in general, in these common variant analyses, things look pretty additive. I will say that in a couple of trials where we found, we've looked actually in this checkmate trial, there's a couple of homozygotes and they're like exceptional responders. And it kind of got us thinking that maybe there is something to the homozygosity.
Yeah.
I'll also show later, biologically, they really do seem to be more active in terms of IL-7 activity. So there could be something there, but the sample size hasn't been large enough. I do kind of wonder like if we should, if we could get the power there, if specificity is the most important part, then maybe even just focusing on the small number of homozygotes for clinical management would be more relevant.
But and also the East Asian population is 30%.
That's right. Yeah, so it'll be like 10%. Yeah.
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 Down a rabbit hole. Do you know whether this is the ancestral allele or?
That's a good question. I mean, generally speaking, the rare this is the less frequent allele we
But
typically
so
derive.
if the less frequent one is the ancestral allele, then it's much easier to figure out what's going on.
Yeah. That's a good point. Yeah, we should. That's an easy thing for us to check.
And I would look at infectious disease.
Yeah, and as
Pretty much thought of it.
But I think one of the few other examples of a treatment response, like a germline treatment response associations for COVID, there are a handful of COVID variants. One of the largest is a Neanderthal derived variant. So you do kind of get these crazy. Yeah, we should look. It's a great point. Okay, so we have now some confidence in the association. We have looked in this normative population and we see that it is specific to immunotherapy. It's not associated with anything that looks like a toxicity in patients who received other treatments. And then this is sort of what I was getting at before, is we sought to connect this variant to the expression of IL-7 itself. So far, all we know is that it's a polymorphism nearby. When we look at gene expression data for non-carriers of this variant, their expression of IL-7 looks like this, and this is where the polymorphism is. When we look at heterozygous and homozygous carriers, you can see that there is a really substantial increase in expression of this little block over here. And again, these homozygotes, you can't really see it in the figure, but they are really like 2 or 3-fold higher expressed on average than the heterozygotes, given the small number. And you can see more junction reads for these individuals than for these individuals. This bit that I'm talking about is not a canonical part of IL-7, but we think it's a cryptic exon that is being spliced in, and it resides immediately next to the top SNP association, which is also algorithmically predicted to be a splice affecting variant. So it all seems to fit together that there's potentially a splicing relationship here. We've additionally, now going back to the melanoma data, observed this variant associated with the expression of IL-7 in single cell expression data, specifically in B cells and specifically in patients compared to healthy donors, the HD here. So again, suggesting that this is both a treatment and a cell type specific effect. I'll skip over the other associations we've seen between this variant. The big question, as I mentioned at the beginning, is it's associated with toxicity. What about response? So in immunotherapy treated patients, we see no association with response or progression whatsoever. It's just all bad news. It just gives you toxicities and nothing else. On the other hand, when we went back to TCGA data, which is now quite old and for whom the majority of collected individuals were not on checkpoint inhibitors at the time because it wasn't yet standard of care, and a big part of the TCGA population was metastatic. Got kind of lucky here. We actually see that this polymorphism is associated with reduced progression or better response for those non-immunotherapy treated patients. And this is in fact like the first germline association with survival that we have observed as well. The hazard ratio here is quite substantial. So putting it all together, the variant is doing something where carriers prior to going on immunotherapy are generally doing better on treatment, but by the time they get on immunotherapy, it's all bad news and they're just developing toxicities. And so this is an invented flowchart, please don't use this, but just kind of thinking about ways in which this polymorphism could be incorporated into stratification. You could imagine that you have a patient with advanced melanoma who's a non-carrier, you can quite confidently treat them with the standard of care or even combination immunotherapy and expect a small number of adverse events. Whereas for carriers, you have to think a little bit harder because on pre-IO treatments, they actually have this variant has a protective effect. But if they go on immunotherapy, they have a 50% chance of developing toxicity. And so again, we think this gets at this sort of interesting treatment specificity and also as a way to really, and this is the way we pitch it to pharma, is to identify these guys down here, the non-carriers that you can give the drug to with more confidence. Although obviously we want to also understand there's a way to mitigate the effect in the carriers.
Do you think
So one strategy for that is to give the drug plus a targeted inhibitor at the beginning and try to minimize the toxicity and also prevent progression to glucocorticoids, because I don't think that there is no survival benefit. You're getting it blunted by the immunosuppression you're giving.
Yeah.
To manage the toxicity. There's probably a survival benefit outside of that setting. You just need to clean that up and maybe give an IL-6 inhibitor or other things early on in the treatment setting to prevent progression.
Yeah, and maybe we can look if just incidentally some people were also given an additional.
Yeah, I mean, there are multiple trials of IL-6 inhibitors
Yeah.
that have been done already. Maybe look at that population.
Yeah, that would be very cool.
Do you think there's a dosing component here too? So for instance, carriers might have the same therapeutic window, but it's shifted. And so now when they go in the clinic, they get checkpoint blockade and we miss the window because we're just giving too much for them.
Yeah.
You actually dial the dose down. You've hit them where, you've got an on-target, on-tumor response and they can tolerate.
Yeah, I think it's a really good question because this effect on non-immunotherapy that's protective is really intriguing, and it suggests that actually either they are just naturally kind of immune active and already
Right.
eternally killing the tumor. They basically have like a natural checkpoint inhibitor early on, and so maybe then you just add a little bit of an increased dose, or the timing matters more. I think the problem is in the data that we have, treatment level information is not that well recorded, and there's not, the variation in dosage is often confounded with other factors. But I think looking in trials, especially where there's variable dosage attempts, would be really helpful for that. Or plugging it into a language model and just having attempts. So with that, again, I just want to sort of conclude that we've been running these analyses of germline variants. We have a number of interesting hits, and once we have these hits, we can use them as instruments to explore all sorts of causal relationships between toxicity and survival. And I want to thank the many collaborators and sort of years of work to put these studies together. Thanks. Any last questions?
One more
Yeah.
comment. You didn't mention it, but if you're not using the sort of independent hypothesis weighting approach, probably should.
Yeah, so one thing we haven't even gone down is we could in principle try to aggregate all of the associations, including the non-significant ones, into a phylogenic score, and there's sort of more intricate ways that we could incorporate.
Yeah, but you could also just say, like, let's take some swath of immune SNPs out of a handful of polygenic scores,
Right.
and then weight those much higher in your GWAS. So you see like this one where you go power of or p-value of 0.05, right? You're treating every SNP as equal, and every SNP isn't equal. You have a very specific question about sort of things that perturb the immune system. That'll probably reduce the number of tests you do by a factor of 10 at least if you're careful about it.
Yeah.
And that gets you, like, for absolutely nothing, no cost, you get that increased power.
Yeah, it's a great point. And I think it actually kind of presents an interesting methodological question of when you have a bunch of external population level data and treatment effects that you think are related, how do you factor them in? The one thing I'll say is that we see no association here at the HLA locus, which really surprised us because that's like the big hit for autoimmune conditions. So I don't know exactly what's going on there and whether these toxicities are, somewhat specific in their genetics.
It's a longer story.
Yeah.
I'll give you an idea of what I think.
Awesome. Okay. All right. Let's catch up.
All right. On that note, thank you to you diehards who made it to the very end. Much appreciated. Thank you to our speakers.